our side event.
Okay.
My, my name is Dr. Andrew Kolodny. I am the medical director for opioid policy research at Brandeis University in the United States. I'm also the president of the NGO that's sponsoring this session, Physicians for Responsible Opioid Prescribing. You are all probably Danny? Can you
I
can you
can
start?
hear you now. I'm sorry, I can't hear anything.
Danny, go ahead. We can hear you.
Okay, great. Hello, my name is Danny Strong. I wrote and directed the award-winning TV series Dopesick, which tells the story of how pharmaceutical company greed led to a public health catastrophe. This tragically dark chapter in U.S. history has been chronicled extensively in over a dozen books by esteemed journalists, multiple documentaries by acclaimed filmmakers, and even big-budget scripted dramas on Netflix, Hulu, and Disney+. Due to this unusually large amount of content for one subject, it is now common knowledge in the United States that a campaign underwritten by opioid manufacturers led to a soaring increase in opioid prescriptions. Doctors were told by pharma reps that millions of patients were suffering needlessly because of overblown fear of opioid addiction. They were told that the compassionate way to treat any complaint of pain was with opioids. And this was followed with the big lie that less than 1% of people became addicted. Now, to push this dishonest narrative, medical evidence had to be falsified to demonstrate the impossible, that an addictive drug was in fact not addictive. So fake studies were commissioned, false pain charts drawn up, and misleading slogans were used to push opioid use by tricking doctors and patients into believing these drugs were much safer than had previously been understood for literally the last 100 years. The big lie ended up creating one of the worst healthcare disasters in the history of the United States. and has been dubbed by Oscar-winning filmmaker Alex Gibney as the crime of the century. As opioid prescriptions soared, so did rates of addiction and crime that led to colossal suffering, with a massive increase in infants born opioid dependent, children placed in foster cares, rising rates of infectious disease, and an enormous death toll of overdoses that is accompanied by millions of devastated family and friends whose lives are shattered. Now, the reason why I'm here today is because other countries are starting to follow in our disastrous footsteps. And just like in the US, the rise in prescribing is leading to increase in opioid use disorder and opioid overdoses. One of my main goals in making the TV show Dopesick was as a warning to other countries, to show the international community how pharmaceutical companies misled the United States to get people addicted to their expensive drugs and that they were going to come for them next. I sincerely hope this warning is heard so that you do not follow in our tragic footsteps. Because if you do, millions more across the globe will become opioid addicted, and potentially millions of lives will be lost and destroyed.
Danny, can you hear me?
Yes.
Okay, thank you very much. Stay with us in case people have questions for you at the end. Thank you.
Sure, no problem.
So I'm going to just very quickly give you an overview of the issue in the United States. This graph is showing you, you able to see my screen? This graph is showing you oxycodone consumption in the United States versus Europe. And you can see the year that the oxycodone consumption exploded in the United States. It's the year 1996. You may know that that was the year that Purdue Pharma introduced OxyContin, and much of that increase is related to the increased prescribing of OxyContin. But 1996 was also the year that morphine went up in the United States. It was the year that hydrocodone went up, hydromorphone, fentanyl patches were being prescribed more. Every opioid that was on the market in the United States before 1996, 1996 is the inflection point. It's when you see prescribing take off. You'll see here on this graph, which ends in 2015, that there's just a slight increase there for Europe. This data covers a little bit more current time frame. This is not just the oxycodone molecule. This is all opioids per capita. It's showing the US versus countries that also have high rates of opioid consumption. You'll see in many countries, prescribing is trending up. This graph ends in 2016. You'll hear from some researchers today who are going to show you the more current data, what's been happening since 2016 with opioid prescribing in these countries. Something to keep in mind when you look at this graph, fentanyl emerged in the United States, illicit fentanyl emerges as a major public health problem in 2014. There is a popular narrative that fentanyl emerged when the pills had dried up, that it was a crackdown on the pills that led to the fentanyl problem. That is incorrect. Fentanyl emerged when we were near the height of prescription opioid consumption, with demand for it driven by people who had become addicted to the pills. You'll see again that the trends in these other nations are concerning. We'll hear more about that. As the prescribing went up in the United States, which is this green line, addiction, which is the blue line, and overdose deaths involving prescription opioids went up in parallel with the rise in the prescribing. Again, you will hear that these trends are repeating themselves in other nations, whereas prescribing goes up, we see an increase in prescription opioid-related harm. Why did the prescribing take off? Doctors in the United States began to hear from many different directions that patients were suffering needlessly because we were under-prescribing opioids. We started to hear that addiction in patients with legitimate pain is exceptionally rare. We started to hear that opioids can be easily discontinued. Don't worry about the dependence. Don't worry about the tolerance, which would require higher and higher doses to get an analgesic effect. We start hearing that these are good medicines for chronic pain. All of these messages were false. Now, doctors in the US would have been less gullible if these messages had only come to us from the attractive drug reps who visit us in our offices. But the messages came to us from every direction. We heard it from pain patient organizations, pain societies, professional groups, the organizations that regulate hospital practice, the organizations that regulate doctors on a state level. From all of these directions, doctors were being encouraged to prescribe more opioids. And this campaign to increase prescribing, much of it was really driven by good intentions. Behind it was pharma money. There was marketing disguised as education and advocacy, but the people caught up in this movement, many of them believed that they were doing good work. Why did the problem get so bad in the US? Why didn't policymakers intervene as the prescribing was exploding? It's because they were making the mistake of accepting a false framework for the problem. This slide is actually taken from a slide that was shown at an FDA meeting in the US, where a pain organization funded by drug makers was making the case against scheduling of hydrocodone combination drugs that we have in the US. The argument here for the policymaker was you need to be balanced. If you put restrictions or controls on hydrocodone, you'll be punishing the pain patient for the bad behavior of the drug abusers. The problem was framed as if all of the harms are limited to so-called abusers, non-medical users, and that patients were being helped. This was totally false. Patients with pain were disproportionately harmed by the overprescribing. Patients with pain suffer disproportionately from overdoses and addiction. This campaign to change prescribing practices was not limited to the United States. This graph comes from an investigation that was done by two members of the United States Congress, a Republican and a Democrat, who did this investigation together. And they looked at the way Purdue Pharma and other drug makers had influenced the World Health Organization in its policies related to opioids. And one of the things that we know that the World Health Organization has done is in not scheduling tramadol, a drug that has become a tremendous problem across the globe. If you listen to the ECD, the committee that makes recommendations, if you listen to their own reason for why they didn't recommend scheduling, despite the tremendous harm caused by tramadol, what they said was the reason is they were concerned about untreated pain. They were falling for this false framework. The WHO has been influenced, but to the WHO's credit, in response to this investigation, it retracted two of the guidelines that it had issued that had really terrible misinformation in them. One of the guidelines promoted aggressive opioid prescribing in children. Unfortunately, the UNODC is continuing to distribute materials that the World Health Organization has retracted and continuing to reference these materials. If you go to the second floor, you may have already seen this stand of this exhibit from UNODC. It's difficult for you maybe to see on the picture, but in those pill bottles is candy. And what it says on those pill bottles is end pain. If you just take a moment to think about this, to think about the metaphor of candy for opioids, what is this really saying? And even the message, end pain, it's showing us that people, I believe, with good intentions are under the impression that the benefits of opioids are greater than they really are. Opioids don't end pain, they lessen pain. And if you're on them chronically, they can actually make pain worse. So it's an overestimation of what opioids can actually do. And it's an underestimation of the risks. If you understood really how addictive and deadly prescription opioids are, would you be using candy as a metaphor? So I'm going to stop here and we're going to go to our first speaker, Andrea.
Thank you very much for the introduction and the invitation to talk today. I'm Andrea Burden. I'm a professor at the ETH in Zurich. And I'm here today to talk particularly about the situation we've seen over the last 20 years in Switzerland. So I'm going to start with a very short historical context, because I think the elephant in the room is that many of you will know that Switzerland in the 80s and 90s did have actually the illicit heroin epidemic. And in a way, we had this massive issue, and Switzerland became a world leader in how they managed it and was very successful in the four-pillar approach to manage opioids. And actually, this system is still ongoing today. However, just because we had great success there doesn't mean that we need to avoid the discussion of prescription opioids, as was already talked about with Andrew, that this is how the situation in the US has unfolded. And no matter what metric you look at, Switzerland typically ranks somewhere in the top 10 in terms of prescription opioid use. When I came to Switzerland, one of the questions that we had was this high prescription opioid use due to the management of the initial opioid crisis with heroin, or was it potentially something more sinister? And looking at the sales data coming from community pharmacy, what we ended up identifying in data from 2000 to 2019 was that the largest growth in sales was around oxycodone use, and the really high selling drug was tramadol. So with these two drugs, it's unlikely that this is related to the management of the heroin crisis, and more due to a kind of influx of prescription opioids in Switzerland. And I know you'll see graphs that look similar to this from other countries as well. In particular with oxycodone, it was quite alarming to see that between 2001 and 2019, it was around a 20% annual increase in terms of the sales that we were observing in the country. There has been work by another one of my colleagues looking at who are these patients, and we see that the vast majority are non-cancer indications. They are females around the age of 55 or 60. And what was quite concerning from this data was that a high proportion, at least 50%, were receiving opioids for more than 3 months, and about 29% were actually receiving opioids for more than a year, and over 100 milligram daily average dose, which is rather alarming in terms of the potential for harm. Now, harm, I think you'll hear many of us speak about this, is the tricky thing. We don't have a lot of great data to assess harm in our country. We did have access to our National Poison Center data, where we could look at the number of calls that came into the Poison Center related to overdoses with opioids. We do see, again, a similar rise, particularly around oxycodone, again, the blue line, but we know this is the very tip of the iceberg. Unfortunately, if you have an overdose with an opioid, particularly as you go towards things like fentanyl, you're not calling the National Poison Center for help. It is more of an emergency situation, so we know we're not capturing the harm completely here. We subsequently have, and this is unpublished data that we've just recently received from the Forensic Institute in Zurich, so the Canton of Zurich, all of the autopsies that were done, keeping in mind that we have very few autopsies done per year in the Canton of Zurich, only around 300. These are all the ones where opioids were detected in the autopsy. We have a rise of about 30% in any opioid. And if I take this chart down to maybe perhaps some of the stronger ones, something that is quite alarming is this growth that we're seeing in the strong opioids such as fentanyl, particularly since 2019, where in all autopsies that were done, at least 10% of autopsies do have fentanyl detected at this point. And my final word that I want to bring up is maybe a bit of a word of caution of something that's not really received a lot of attention. As we've talked, it's not just oxycodone and not just Purdue or Mundy Pharmaceuticals, but we're starting to see now a big rise in the sales around Pentadol. And this is data that is also unpublished that we actually just received, looking at Germany, Italy, Switzerland, and Austria, so kind of our surrounding countries, in terms of recent sales per 1,000 inhabitants. And we can see a really stark rise in the sales around Pentadol in the last 10 years, and something that we should probably keep our eyes on in regards to harm. And so just to end with kind of our message from Switzerland, I'm sure it will be the same from my other panelists, is that we continuously see this rise in the sales of prescription opioids, particularly oxycodone and now Pentadol. We have a high amount of patients who are using these for long-term and in high doses. And we do have indication of harm that is rising, but we need to be cautious that we have limited data here. And we really need the support to actually develop bigger systems so that we can actually monitor this a little bit more closely so we can actually understand what's going on before it happens and not be reacting after the fact. With that, I'll hand over back to Andrew.
Thank you.
So my name is Evelien van Dorp. I'm the next panelist in line. I'm from the Netherlands. I'm an anesthesiologist and an epidemiologist. And in that case, I work in the Leiden University Medical Center. And I'm also a member of a large research consortium in the Netherlands where we have worked together with 3 other academic hospitals and an academic pharmacy to found a research consortium tackling and preventing the opioid epidemic, in which we try to see whether there is a problem in the Netherlands. We started this in 2018, and just after I started this, I attended a large anesthesia conference in the United States, where I was aware that there was a problem in the United States, but I wasn't aware that it was a crisis. And the fact that at an anesthesia conference, the Surgeon General told us all not to bother with learning basic life support, but just to carry naloxone, because we would save more lives that way. That is something that you cannot say to anesthesiologists usually, because we pretend to like to save lives. That was an eye-opener for me, so we knew we were on the right track. Well, my top 2 colleagues, we thought, well, let's see whether Europe is like the United States. And my Nijmegen colleagues they investigated an opioid crisis in all of the Dutch countries. Well, this is basically the slide that Andrew already showed, in which we see in different countries, we see an uprising trend in use of opioids, and the brown line in the middle is the UK. And the UK this is total prescription opioid consumption. In the UK, you see an explosion. And you see in the UK as well, you see an explosion in opioid deaths as well. Opioid overdose deaths and heroin overdose deaths, you see them rising at 22.7 per 100,000 inhabitants. That's almost as bad as it was in the United States in 2021. In the meantime, it has grown quite exponentially. But this is something to think about, that in Scotland, in the UK, which is, well, sort of Europe still, there is a problem as well. Well, that's my Nijmegen colleagues. What happened in the Netherlands is what we investigated. What you see here is the sort of heat maps. The lighter the area is, the lower the opioid prescription is. And what you see happening is from 2008 to 2016, so in 8 years' time, you see in most areas the amount of opioids per the amount of opioid prescription per 1,000 inhabitants quadruple. So that is quite impressive and quite worrying as well. We went to work with that, and we published 2 large papers on opioid prescription patterns. And what we saw is that opioid prescriptions in the Netherlands grew from 4.9% in 2012 to 6.0% in 2017, which means that in 2017, over 1 million Dutch people have received at least 1 opioid prescription. We are a country that is known for being small. We are 17, well, in the meantime, we've become 17 million people, but that means 1/17 of the population is had an opioid prescription in 2017, and that is worrying as well. The hospital admission for opioid overdose increased dramatically by an absolute number of the relative number of 68%, for the absolute numbers, but from 9.2 per 100,000 to 13.1 per 100,000. So that's all opioids in admission, but this is just the tip of the iceberg. These are the codes where we know that opioids were used. We're not sure whether traffic accidents, people falling, people coming in with a cardiac arrest of unknown origin, all those people were still missing. And are some people using opioids there as well. And the same goes for the opioid deaths. We saw a 65% increase of opioid deaths in those same 5 years, and that's really worrisome. Our colleagues in Nijmegen checked which opioids were used, and what you see is basically tramadol has plateaued, but it's still by far the most used opioid in the Netherlands. And from the year 2012, 2013 onwards, you see a rapid rise in the blue line, that's oxycodone. And then what you see is the opioids that are implicated in hospital admissions in the Netherlands start to change from the moment that oxycodone prescriptions start to rise. Because what you used to see, there was this really stable population of people, remnants, relics of the old heroin addiction epidemic in the 1980s. Those seem stable. That's the blue line in the right picture. But what you see is a sharp rise in people being admitted to hospital for the use of prescription opioids. And that is something that we as doctors probably had a hand in, because as Andrew said, it's all from good intentions, but what we were told in 2011 that patients were not allowed to be in pain after surgery, and actually hospitals were being punished for having people with high pain scores. So the logical thing is that what happens is you give a new guideline and you start treating pain very aggressively. And if you look at the graph, so we decided pain was a quality endpoint. So, and then we gave people more painkillers, and then people started to be admitted to hospital for using those painkillers. Same here, what you see is the mortality caused by heroin, methadone, and the classic opioids remains more or less stable, and it starts to rise from 2014 onwards for prescription opioid poisoning, as well as a rise in people seeking addiction care in the Netherlands for an opioid addiction. You see a very slow downslope in people seeking it for classical opioids and for the prescription opioids, or the classic opioid addicts, and you see more and more people seeking it for prescription opioids. So there's an increase in use in the Netherlands. There's a different population with more prescription opioids causing dependence, and there's a large role for OxyContin, especially after the introduction of a new guideline and new, hospital measures. So who are these people? They're usually elderly. People over 65 years old have a four times higher chance of receiving an opioid prescription than those of 90 to 35 years old. Women are more likely to receive it, and people reporting feelings of loneliness and depression, as well as poor physical health. And poor physical health is a difficult one, because you also get prescribed opioids because you're in a poor physical health, because that comes with pain, but still an odds ratio of 10.4 is unheard of in any epidemiological paper, basically. And I would like to look in a bit more detail about the non-malignant pain, because people would expect patients with cancer, with the diagnosis of cancer, to be prescribed opioids. Well, this was the case. People with cancer had a three times higher chance of being prescribed an opioid than people who did not have cancer. But people with neck or shoulder pain, a diagnosis of neck or shoulder pain, also had a 3 times higher chance of being prescribed an opioid than those not having that. And those with back pain had a 4.3 times higher chance of receiving an opioid prescription. And this is something that is very, very worrisome. So my basic take-home message is that the opioid use in the Netherlands is still nowhere near American levels, but it has increased dramatically over the past 10 years. And if you look at data from 1996 to 2005 in the States, we're basically at that level. And prescription risk of opioid use is higher in non-malignant pain, in females, and in those with poor physical and mental health. And we need to be not only aware of the risk, but we need to change prescription practices here. So that's the only way we can prevent this crisis from deepening. Thank you very much.
Marco?
I hope everyone can see this. So I'm Rocco Freeland. I'm a health economist based in London at the London School of Economics. I am the director of the Global Surgery Policy Unit, which is a partnership between the London School of Economics and the Royal College of Surgeons of England. I work a lot with governments across Africa, specifically around surgical system strengthening or healthcare system strengthening. More generally, I'm special advisor to several ministries of health across various African countries, and I also work with the WHO on the implementation of the World Health Assembly Resolution 76.2 on the integration of emergency, critical, and operative care. The work that I'm going to present today, together with my colleague, Dr. Mainu, who's going to introduce herself when she starts talking about Spain and Germany, is about the increasing trends in opioid prescriptions in the UK, specifically England, and the harm that is associated with the trends that we have been observing. Okay, so this is, in line with what has already been mentioned several times before. You know, this graph was produced by colleagues of mine at the London School of Economics, showing the distribution of prescriptions across different countries. You can see a clear link between high and low middle income countries, or higher income countries showing a higher rate of prescriptions and consumption of opioids. We are going to focus on Germany, the UK, and Spain in particular. And as you can see on this graph, those are the countries that show the highest level of consumption within, the global spread of consumption that's presented in this paper. Okay. Okay, so what has happened in England? It was mentioned before by my colleague Andrea that we have seen significant increases in opioid prescriptions in the UK. This is taken from a paper that was produced on the back of an effort by Ben Goldacre at Oxford University to combine opioid prescription data or prescription data more generally and make it publicly available for individuals to see what the regional variation looks like and what the different components, the different drugs are that are being prescribed. What you can see, in line with what has been mentioned, between 1998 and 2016, there has been a significant increase in prescribed opioid prescriptions in the UK, increase of 120% over that period. Most notably, tramadol being one of those areas, one of the drugs primarily responsible for the increase that has been observed in the UK. But what this graph doesn't show is what has happened after 2016. And if you look at the recent data, the UK has made quite significant progress or effort policy-wise to try and reduce the increase that has been observed over time, and with prescriptions essentially plateauing post-2018 and remaining at the level that we've been observing in this graph. Regardless of the plateauing of prescription rates, we do see quite significant variation across different parts in England. As you can see on the left-hand side, you have London and the Commission Group in London reporting rates of about 25 per 1,000 patients, whereas in comparison, the northwest of the country has almost 70 prescriptions per 1,000 population. So you can see quite significant regional variation, and in our research, we've been trying to address where those changes or where the difference may be coming. And I will talk about this in a few slides. The starting point of our work was to look at publicly available data produced by the Office of National Statistics to look at the trends in opioid-related drugs, opioid-related deaths, broken down by opioids, heroin and morphine and methadone. And as you can see, there has been a significant increase, again, far off the rates that have been observed in the United States, but nonetheless increasing trends that go hand in hand with the rise and the change in prescription practices that we have been observing in the previous slide. What we have then done is to look specifically at hospital admissions. So instead of just looking at mortality as an outcome measure, I think when it comes to assessing the harm of opioid prescriptions, it's very useful to look at other outcomes. We've been using administrative hospital data in the UK. So essentially for every patient who's been admitted to a hospital, we do know what the diagnosis were, what their patient demographic characteristics were, and what the treatment was that they received. And what I'm showing in this graph, in these two graphs, is actually how the changes in opioid admissions is quite remarkably delinked from other emergency admissions. So from about 2011, we see quite a significant, almost a 60% increase in hospitalizations related to opioids. And on this bottom graph, if you compare those hospital admissions related to opioids to other drugs and alcohol admissions, you can again see quite a significant difference. And what we've been trying to do is sort of disaggregate who those individuals are who have suffered hospitalizations. And please keep in mind that we're only talking about individuals who have actually been admitted to the hospital. These are not individuals who only come to the A&D department, for example, who receive treatment and then were able to go home. So this is likely an underestimation of the harm that has been experienced by the population in England. We separated, disaggregated our data into different patient groups, age groups, looking at different measures of clinical complexity, specifically the mobility index and socioeconomic deprivation. And what we have found is that the highest proportion of hospitalizations was concentrated among younger individuals in England, so between 25 and 44 years of age. But we've seen a 160% increase for individuals above the age of 55. In terms of clinical complexity, it's individuals, so hospitalizations were concentrated amongst individuals who do not have any underlying comorbidities. So the Charlson Comorbidity Index captures a number of comorbidities, I think up to 14 different indicators, different conditions, and hospitalizations were concentrated amongst individuals with no underlying conditions. But we saw the largest increase in hospitalizations for those who suffer from more than 4 conditions. Again, if you look at the number, quite a significant increase. And then finally, very often high levels of opioid abuse is associated with high levels of deprivation. What we have found is, of course, that is the case in England, but we have seen the largest increase in hospitalizations for individuals who actually living in the least deprived areas in the UK. So again, this is food for thought. This is the last slide that I just want to conclude with. We have also been trying to understand what are the driving forces behind the harm in terms of mortality and hospitalizations in England. And we have published a study in Social Science and Medicine looking at how different spending cuts, so cuts to welfare regimes that have been observed across different parts in England to the expenditure, the budget that local authorities have available to provide for social services, welfare support locally, how that translates into the uptake of opioids and ultimately, the consequences of death and hospitalization. What we have observed is that areas in England that have received the largest spending cuts, some regions receive spending cuts in real terms of up to 50%, so really significant cuts into their budgets, have ultimately experienced the largest increases in mortality and hospitalizations. So really highlighting this interplay of unemployment, welfare, and how that translates into the uptake of opioid drugs, and then translates into adverse outcomes. So thank you so much. I will just hand it over to my colleague. Yeah, sure.
So, first of all, thank you very much for inviting us to present in this panel. I'm going to continue with what my colleague was talking about. Just before, let me introduce myself. I'm Laia Maino, and I'm an assistant professor at the University of Barcelona, and I'm also a visiting fellow at the London School of Economics. and I'm a health economist, so I do research in this area. So let me talk about Spain and Germany. So basically, I will follow more or less the same takeaway messages of what we've seen already in Switzerland and Netherlands and the UK. So we see an increase in opioid prescriptions and also on opioid-related harms in both countries. Let me go deep in Spain. In Spain, what we see is an increase in prescriptions, nearly 100% from 2010 to 2021. So there's something going on in Spain too. The main opioid that is being prescribed is a combination of paracetamol and tramadol, but it's followed quite closely with fentanyl. So there's something that it needs to be taken into account. And what you see, this next graph is very similar. So from the total number of opioids prescribed, basically close to 50% is this combination of tramadol and paracetamol, and then followed by fentanyl, which is more or less close to 18%. So these are the main main opioids that are being prescribed in Spain. What's interesting to see in Spain, and that's something that we haven't touched in this panel yet, it's who are the prescribers. So, and if we want to tackle the problem, we really need to know how this opioid prescription is coming into place. So in Spain, this is a paper from Regueras Escudero and López Guzmán that had a lot of data in prescription, and they saw in the years 2019 and 2020 that basically all these opioids that I'm showing in this graph are basically prescribed by the primary care physician. So in Spain, what's happening is that basically the GP is the one doing the prescription of this type of these opioids. So if we wanna tackle that problem, that's something that we need to take into account. What are the prescriptions for? Basically, the diagnoses are for back pain, cancer, and arthritis. So these are the main three groups. And who are the ones prescribing it? In which clinical areas? Traumatology, rheumatology, and oncology. So it's not only for cancer pain. So we see opioid prescriptions going far beyond that in Spain. So can we relate opioid prescription to any harms? So yes, we can relate that too. So we see that opioid-related deaths in Spain are increasing from 2010 onwards. This graph is it's from a paper Salazar 2023, but these deaths are all opioids, both prescribed and illicit. But what we can say is that on what the paper says is that in Spain, basically, illegal opioid consumption hasn't really increased. It remained quite stable in this period of time. So what they attribute to increase in death is basically to prescribed opioids. So there's something going on between the prescription and the mortality that we see in Spain. We haven't done anything yet on admissions. That's what my colleague was saying, that we did in the UK, but that's our next goal, because that is the final, the ultimate, the last point. We want to see what's happening before and see a bit more on that, on what are the trends in Spain. So let me go into Germany. We can see something similar. We can see an increase in opioid prescription trends. The first graph on the left-hand side shows the comparison between opioids and all the others analgesics that are prescribed. We clearly see an increase and a difference between the two groups. And what we also see on the right-hand side is the total volume of prescriptions, which basically the biggest one is fentanyl and ivermorphine. So that's interesting because what we see in the data is that fentanyl, it's basically prescribed for back pain, arthritis, and pain related to osteoporosis, which is not really covered in the clinical guidelines. So that's something to take into account. Giving you some numbers on the cost, around 1 billion is attributed to opioid prescriptions from the national health, so the statutory health insurance, which is the public insurance in Germany, and that accounts for 2% of the total pharmaceutical cost. What another data that we found is that 20,000 individuals are addicted to painkillers in Germany, including opioids. Is that can we find a relationship between that and between prescription and mortality? what we find in the data is that there is a mortality due to drug-related mortality. 70% of that is related to opioids. And if you see in this graph, it's increasing every year. So that's something also going on in Germany. It's true that opioid prescriptions have increased in the 3 countries that we looked at. We are still doing more analysis on Germany and Spain because we want to look at admissions and trying to disaggregate who are the patients affected, what type of patients are affected. But we see an increase. It's true that it's lower than what we see in the US, but still a cause for concern. So we need to take that into account. So there's more prescriptions, and that's linked to more opioid deaths and admissions. What we know, what we've seen in the data also is that 1 in 10 people that are prescribed opioids suffer moderate harm. So that's the translation on prescription and harm. We see in all these countries prescription for cancer and not cancer patients, while there's not enough evidence showing that we should treat chronic pain with opioids because that creates dependence. So, but still we see that in the data. One nice number that we found is that for every 62 people that have been prescribed opioids for chronic pain, 1 of them will die, compared to all these people that they haven't been treated with opioids, that we could find all the treatment for these people. What can we do, or what's happening? What are the governments doing now? They are trying to limit that consumption. We can see what's happening in the US, so we are trying to, in Europe, we are trying to do something. There are some guidelines already that show how we should prescribe correctly. We've seen some limits on the dosage and time. There's been some removal of selective opioids from the drug schedules. There's prior authorization, access to the treatments, and monitoring. So these are different things that some countries have been implemented. And there are the new guidelines for England or also for Spain on medicine optimization, which really tackle opioids. And one interesting factor that the UK is they are trying to reduce year by year the opioid prescribing by 10%. So by doing that, they want to do that for the next 5 years, trying to reduce the number of prescription, and due to that, reducing harm on these people. So there's an important objective in the UK. So that's it. Thank you. And
Great. So, so if I can get the slide. So very quickly, it's a pleasure to be here. I'm, in terms of introduction, I'm a health policy researcher at Brandeis University in the US. But I'm also a Nigerian pharmacist, and I've worked in the front line of the tramadol crisis in Nigeria. And I just believe there's a connection between sort of the rising prescribing in Europe and other parts of the world, and what we see in Nigeria, tramadol crisis. So just very quickly, I see we're running out of time. I want to make just very few points. Most of the speakers that have spoken today have commented on tramadol as a major driver of the opioid consumption in Europe. And even though tramadol is scheduled in Nigeria, it continues to flood the Nigerian market because it is not scheduled internationally. So it gets smuggled into Nigeria from other countries where it is not scheduled, and so that's a problem. And just like Andrew had said earlier, the main reason why tramadol, why opioid prescribing is rising in Europe as it did in the US, is also the same reason why the WHO is yet to schedule drugs like tramadol internationally. And this is the fact that drug companies, and I'm just going to borrow Andrew's slide here, is the fact that drug companies continue to market opioids in disguise as an advocacy for treating pain. And in developing countries, the story is it's about making pain treatment accessible. That's sort of the big story that you hear from advocates for increased use of opioids. And so just one main point that I would like to make is tramadol needs to be scheduled internationally. I think that's going to be a major, it would be a major solution that we have to some of the tramadol crisis we have in Nigeria and some parts of West Africa. until this happens, tramadol use will continue to result in increasing numbers of people with OUD and to create a growing market for heroin, fentanyl, just like we saw in the US. 2 points that I've been speaking to a bunch of delegates, and 2 things that I continue to see are required. I think we really need to, there's an awareness problem about sort of the harms of drugs like tramadol. I think most of the marketing and advocacy for increased use of tramadol sort of downplays the problem of tramadol. That's one side to it. The second side to it is there's less awareness about the, just substitutes for tramadol. There are other more effective, safer, more accessible options, alternatives to tramadol, like non-steroidal anti-inflammatory drugs. There's evidence out there that they are as effective, more accessible because you don't require a prescription for them, and safer than tramadol. So I think that awareness has to be, there needs to be a lot done around awareness about that's on one side. I also think that there needs to be more forceful regulation of the distributors and manufacturers of opioids like tramadol. I particularly am concerned that Grunenthal, for example, has such a strong influence on the ECDD, and just the messaging that is out there about the use of tramadol and other drugs is unfortunately one of the reasons why it is not scheduled internationally. So I think some more work has to be done around just forcefully regulating distributors and manufacturers. So thank you.
Thank you.
Yeah.
We have one more speaker. Gunnar, do you want to unmute yourself? And I'm going to pull up your slides as you get started.
Yes, thank you, Dr. Kolodny. Yes, I'm Gunnar Ågren. I'm a former Director General of the Swedish National Institute of Public Health. But the data I present are from an independent research project where we have made use of official data. And what we have studied is oxycodone-related deaths in Sweden. Next slide, please. During the study is based on data from all forensic examinations in Sweden, and we have linked the data with information from the cause of death register, and we have also included data from the National Prescribed Drug Register. And more than 90% of all cases of unnatural deaths in Sweden, including intoxications in person below 65 years of age, have undergone forensic investigation. And also the case of death register, cause of death register, and the prescribed drug register, they are comprehensive register for the whole population. The study period is 2006 to 2018, but in this presentation we have also added data from the National Board of Forensic Medicine on cases where oxycodone is a cause of death. And those data have been added regarding the period 2018 to 2022. And here are the data on the prescriptions per 1,000 inhabitants in Sweden during the entire period. And you can see that there is increase during the whole period. And the next slide will show that there we have added on the left axis the number of deaths, both from our forensic research register, which were used, and we have also for the 2018 and to 2022 added data from the Board of Forensic Medicine. And you can see that both the number of deaths and the number of prescriptions have increased during the whole the entire period. And our main results, I will add them, are that for the number of fatal oxycodone-related intoxications had increased from 1 per million to 11 per million during this period, 2006 to 2022. I can also say that the oxycodone-related deaths are about a fifth today of the total number of opiate-related deaths in Sweden. The number of prescriptions has also increased, and there is a strong correlation with the annual mortality rate. The increase is largest in the age group 45 to 59 years. And the oxycodone-related cases compared with other opioid-related deaths, they are older, and there are also a higher proportion of females among the oxycodone deaths. The majority of the oxycodone deaths have been prescribed opiates for pain quite recently, and more than 50% had recent prescriptions of oxycodone before the fatal intoxication. And we have made our main conclusions is that oxycodone is today the most common opioid in fatal intoxications in Sweden. And there has been an ongoing increase during the period 2006 to 2022. In contrast, the number of heroin intoxications, which previously were regarded as the main opioid problem in Sweden, that rate has been a quite stable level during the entire period. And if we can add also, we have had an increase in the total number of opioid intoxications in Sweden during the two last decades, but this increase is mainly due to prescribed opiates, mainly methadone, buprenorphine, and now it is more oxycodone, which is the main fatal opiate. And one conclusion we have made is that that is probably a lack of awareness in the Swedish health service about the addictive properties of oxycodone. And that's, thank you, Mr. Chairman.
Thank you, Gunnar. And thank you, everybody, for coming to the side event. Unfortunately, we're out of time, so we're being asked to leave the room. Hopefully, the panelists will be able to stay in the hallway and answer any questions that you might have directly for them. Again, thank you all for coming to the presentation.